Lewis's Medical Surgical Nursing, 11th edition, Chapter 10, Substance Use Disorders. Substance use is a serious problem affecting society and the healthcare system. Substance-related disorders involve several types of substances, ranging from widely used and accepted tobacco and alcohol to illegal, brain-altering drugs such as heroin and cocaine. The Diagnostic and Statistical Manual of Mental Disorders 5, DSM-5, outlines criteria used to identify the presence of substance use disorder, SUD, Table 10.1. Let's go ahead and take a look at that. Table 10.1, Criteria for Substance Abuse Disorder. The following criteria, clustered in 4 groups, can be used to identify substance use disorder, SUD. The severity of SUD can be classified as mild, 2 to 3 criteria, moderate, 4 to 5 criteria, or severe, 6 or more criteria. Impaired control, taking more or for longer than intended, not quitting use despite multiple times of trying to do so, spending a great deal of time obtaining, using, or recovering from use, craving the substance. Social impairment, missing school, work, or other responsibilities due to use, continuing use despite problems caused or worsened by use, giving up or reducing important activities because of use. Risky use, recurrent use in hazardous situations, continued use despite causing worsening problems. Pharmacologic dependence, physical tolerance to effects of the substance, presence of withdrawal symptoms when not using or using less. Whether SUD is mild, moderate, or severe depends on the person's pattern of use and the functional impact of use on the person's daily life. Knowing the severity of substance use allows the healthcare team to tailor treatment according to the patient's needs. For example, a person who binge drinks may not have alcohol SUD, but is at increased risk for it. On the other hand, a person who uses heroin or cocaine is likely to have severe SUD because these substances are highly addictive. Many patients with substance use problems receive acute care for problems associated with substance use. SUD does not exist in isolation. There are many interrelated concepts depending on the patient's situation. Every drug associated with SUD harms some tissue or organ. Substance use causes specific health problems, such as liver damage related to alcohol use or lung cancer related to smoking. Other problems result from injuries associated with substance use, such as falls or motor vehicle accidents. Common health problems related to substance use are outlined in Table 10.12. This chapter focuses on the role of the medical surgical nurse in identifying and managing the patient with SUD in the acute care setting. A hospitalized patient who uses substances can develop withdrawal when substance use abruptly stops. You need to be able to recognize substance use and its effects on health problems and manage withdrawal. The healthcare setting offers an opportunity for screening and provides teaching about substance use. It is your responsibility to motivate the patient to change behavior and refer the patient to programs that offer treatment. Drugs associated with substance use disorder. Nicotine. You're most likely to encounter people with tobacco use disorder, TUD. People with TUD are dependent on the drug nicotine due to using tobacco products. Several products contain nicotine, including smoked tobacco, cigarettes, cigars, pipes, smokeless tobacco, chew, snuff, or dip, and some electronic cigarettes. Cigarette smoking is the main form of tobacco use in the United States. Effects of use and complications. Nicotine is a central nervous system stimulant. Within seconds of entering the body, nicotine reaches the brain, causing the release of adrenaline and creating feelings of a high or buzz. The effects last about 1 to 2 hours before withdrawal symptoms occur, leaving the person feeling tired, irritable, and anxious. The need to have the high or buzz feelings again makes the person crave more nicotine, leading to addiction. Smoked tobacco is the most harmful method of nicotine use. Smoking harms nearly every organ in the body and reduces the general health of smokers. More than 14 million persons in the United States have a smoking-related disease. Smoking causes lung disease, cardiovascular disease, and lung and other cancers as a major factor in many other conditions. Figure 10.1. Although those who use smokeless tobacco have less risk for lung disease, use can cause serious health problems. Holding tobacco in the mouth is associated with periodontal disease and cancer of the mouth, cheek, tongue, throat, and esophagus. Smokeless tobacco users experience the systemic effects of nicotine on the cardiovascular system, including the risk for heart attack and stroke. The use of electronic cigarettes, or e-cigs, continues to increase. E-cigs have a similar look and feel of traditional cigarettes. These battery-operated devices turn nicotine and other chemicals, including propylene glycol and flavorings, into an aerosol. Emerging information shows e-cigs can be harmful. E-cigs may affect the respiratory and immune system. Those containing nicotine may increase the risk for cardiovascular problems and influence brain development in adolescents and pregnant users. Other problems, such as poisonings and facial burns from device explosions, have occurred. Although some believe using an e-cig may aid in smoking cessation, no e-cigs are FDA approved. Do not recommend them as a smoking cessation aid. Nursing and interprofessional management, tobacco use disorder. Tobacco cessation. As a nurse, you have a professional responsibility to help people stop smoking or using tobacco. The Joint Commission mandates that every health professional must identify tobacco users and provide them with information on ways to stop using tobacco. Patients who receive even brief advice and intervention from you are more likely to quit than those who receive no intervention. With each patient encounter, encourage the patient to quit and offer specific smoking cessation interventions. The Agency for Healthcare Research and Quality has issued clinical practice guidelines for clinicians, including nurses, to use to motivate users to quit, tables 10.3 and 10.4. Use these brief clinical interventions, called the 5 A's, with each patient encounter. These interventions will help you identify tobacco users, encourage them to quit, determine their willingness to quit, assist them in quitting, and arrange for follow-up. Patient Teaching Guide, Table 10.5, expands on the fourth strategy, assist to help you aid the user willing to quit. If a tobacco user is unwilling to quit, using the 5 R's may motivate the user to quit in the future. A variety of smoking cessation products are available to help support users in quitting. These include prescription medicines as well as over-the-counter products such as skin patches, lozenges, and gum. Nicotine replacement products are one type of smoking cessation product. These products reduce the craving and withdrawal symptoms associated with cessation by supplying the body with smaller amounts of nicotine. Table 10.6. Because most healthcare facilities are tobacco-free environments, admitted patients who are addicted to nicotine may experience withdrawal symptoms since they are unable to smoke. These symptoms are the same as for the person who stops using tobacco cold turkey. Offering nicotine replacement therapy to every patient who wants to quit will help control withdrawal symptoms during hospitalization and promote continued cessation after discharge. Non-nicotine products also play a role in helping users quit. Varinicline, Chantix, is a drug used to aid smoking cessation. Varinicline is unique in that it has both agonist and antagonist actions. Its agonist activity at one subtype of nicotine receptors provides some nicotine effects to ease withdrawal symptoms. If the person does resume smoking, its antagonist action blocks the effects of nicotine at another subtype of nicotine receptor, making smoking less enjoyable. Bupropion or Zyban, an antidepressant drug, reduces the urge to smoke, reduces some symptoms of withdrawal, and helps prevent weight gain associated with smoking cessation. Along with using a smoking cessation product, users who wish to quit are more likely to succeed if they take part in a tobacco cessation program. You should be aware of available community resources. Cessation programs may involve hypnosis, acupuncture, behavioral interventions, aversion therapy, group support programs, individual therapy, and self-help options. Many of these programs teach users to avoid high-risk situations for smoking relapse, e.g. those that promote cue-induced craving, and help them develop coping skills such as cigarette refusal skills, assertiveness, alternative activities, and peer support systems. Alcohol. Of Americans ages 18 or older, 70% consume alcohol. Most people use alcohol in moderation. Risky drinking is consuming more alcohol than the amounts in guidelines established by the National Institute of Alcohol Abuse and Alcoholism, Figure 10.2. Risky drinking can have negative physical, emotional, and social consequences. Alcohol use disorder, AUD, or alcoholism, affects about 6.2% of U.S. adults. A higher percentage engages in periodic excess alcohol use. Binge drinking is consuming 5 or more alcoholic drinks for males or 4 or more alcoholic drinks for females on the same occasion at least once per month. Effects of use and complications. Alcohol affects almost all cells in the body. Changes levels of neurotransmitters in the CNS, affecting all areas and functions of the CNS. These include centers that control our impulses, mood, and behavior, coordinate motor activity, and promote respiratory and cardiac function. The immediate effects of alcohol depend on a person's susceptibility to alcohol and the blood alcohol concentration, BAC. For the person who is not dependent on alcohol, the BAC generally predicts alcohol's effects. The relationship between BAC and behavior is different in a person who has developed tolerance to alcohol and its effects. The tolerant person is usually able to drink large amounts without obvious impairment and perform complex tasks without problems at BAC levels much higher than levels that would produce obvious impairment in the non-tolerant drinker. Women have higher blood alcohol levels than men do after the same amount of alcohol intake. Alcohol use is linked to many health problems, Table 10.7, which are often the reason that people seek health care. Long-term alcohol use can lead to hypertension, heart disease, stroke, liver disease, and digestive problems. Short-term, excess alcohol use increases the risk for injury from motor vehicle crashes, falls, firearms, assault, drowning, and burns. Patients with AUD undergoing surgery may have increased in-hospital death rates and longer lengths of stay. Complications may arise from the interaction of alcohol with commonly prescribed or OTC medications. Those that interact with alcohol in an additive manner include antihypertensives, antihistamines, and anti-anginals. Alcohol taken with aspirin may cause or worsen GI bleeding. Alcohol taken with acetaminophen may increase the risk for liver damage. Taking a CNS depressant with alcohol can increase or potentiate the effect of both. An alcohol-dependent person may have cross-tolerance, needing higher doses of CNS depressants to achieve the desired effect. Nursing and interprofessional management, alcohol use disorder. Acute alcohol toxicity occurs when a person has a high level of alcohol in the blood, generally after ingesting a large amount of alcohol. This leads to behavior changes and alcohol-induced CNS depression, resulting in respiratory and circulatory failure. Unconsciousness, coma, and death can occur. Other common effects include hypokalemia, hypomagnesemia, and hypoglycemia. Obtain as accurate a health history as possible and assess for injuries, diseases, and hypoglycemia. No antidote for alcohol is available. Implement supportive care measures to maintain airway breathing and circulation, the ABCs, until the alcohol metabolizes. Frequently monitor vital signs and level of consciousness. Treat alcohol-induced hypotension with IV fluids. Patients with hypoglycemia may receive glucose-containing IV solutions. IV thiamine may be given before or with IV glucose solutions to prevent Wernicke-Korsakoff syndrome, which can cause seizures and brain damage. Many patients have low serum magnesium levels and other signs of malnutrition, so HCPs often add multivitamins and magnesium to the IV fluids. Agitation and anxiety are common. Stay with the patient as much as possible, orienting as necessary. Assess the patient for increasing belligerence and a potential for violence. Since the patient is at risk for injury because of lack of coordination and impaired judgment, Use protective measures. Alcohol withdrawal syndrome can develop in a hospitalized patient when the use of alcohol abruptly stops. The onset of AWS is variable depending on the quantity, frequency, pattern, and duration of alcohol use. The early signs usually develop within a few hours after the last drink. They peak after 24 to 48 hours and then disappear unless the withdrawal progresses to alcohol withdrawal delirium. Alcohol withdrawal delirium is a serious complication that can occur from 2 to 3 days after the last drink and last 2 to 3 days. The greater the patient's dependence on alcohol, the greater the risk for alcohol withdrawal delirium. Death may result from multi-organ dysfunction, dysrhythmias, or peripheral vascular collapse. Management begins with identifying at-risk persons. Use a symptom assessment tool, such as the Clinical Institute Withdrawal Assessment of Alcohol Scale Revised, or CIWA-AR, to determine treatment. Table 10.8. Table 10.9 presents the clinical manifestations and suggested treatment for AWS. A nursing care plan for a patient with AWS is available on the website blah 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 blah. Use of other substances. Stimulants. Amphetamine-related stimulants are highly addictive substances. While the use of crack cocaine and methamphetamine is illegal, amphetamines have a role in treating narcolepsy, obesity, and attention deficit disorder. Though most people responsibly use prescribed stimulants, prescription stimulants are often misused. All stimulants increase cardiac activity and excite the CNS by increasing levels of norepinephrine, serotonin, and dopamine. People use these drugs to produce feelings of euphoria, increase alertness, and boost their energy. Health problems associated with using stimulants are outlined in Table 10.2. Nursing and interprofessional management, stimulant use, toxicity. Patients with stimulant toxicity present with sympathetic overdrive, increased stimulation of the sympathetic nervous system. The patient has restlessness, agitation, delirium, impaired judgment, and paranoia with psychotic symptoms. Physical effects include hypertension, tachycardia, fever, pupil dilation, seizures, confusion, and diaphoresis. Death may occur from stroke, dysrhythmias, and myocardial infarction. The emergency management depends on clinical manifestations at the time of treatment. Table 10.10. A specific antidote for stimulant toxicity is not available. Treatment focuses on supportive care measures. Withdrawal. Stimulant withdrawal is usually not an emergency. Abrupt cessation can lead to a crash. The patient may be depressed and experience fatigue, disturbed sleep, vivid dreams, general aching, irritability, increased appetite, and mood swings. Craving for the drug is intense during the first hours to days of drug cessation and may continue for weeks. Supportive care includes providing a safe, quiet environment and allowing the patient to sleep and eat as desired. If a patient has severe depression, initiate suicide precautions and refer for further treatment. Depressants. Commonly used depressants include sedative hypnotics and opioids. Depressants have a rapid development of tolerance and dependence. The use is associated with many medical emergencies involving toxicity and withdrawal. The majority of drug overdose deaths involve an opioid, either also or in combination with another depressant, e.g. opioid and benzodiazepine. Common health problems resulting from depressant use are outlined in Table 10.2. Sedative hypnotics. Common sedative hypnotic agents include barbiturates, benzodiazepines, and barbiturate-like drugs. Sedative hypnotic drugs depress the CNS, causing sedation at low doses and sleep at high doses. Their use produces a euphoria and intoxication that resembles that of alcohol. Tolerance develops rapidly to the effects of these drugs, requiring higher doses to achieve euphoria. However, tolerance may not develop to the brainstem depressant effects. As a result, an increased dose may trigger hypotension and respiratory depression, resulting in death. Opioids. Opioids include substances directly derived from the opium poppy, e.g. morphine, semi-synthetics, e.g. heroin hydromorphone, and synthetic compounds, e.g. fentanyl. Persons dependent on opioids include those who use illegal drugs sold on the street and those who misuse prescription opioids. Opioids act on opiate receptors and neurotransmitter systems in the CNS, causing sedation and analgesia. The person taking an opioid experiences euphoria, mood changes, mental cloudiness, drowsiness, and pain reduction. While this makes prescription opioids useful in treating a number of medical conditions, their pleasurable effects promote misuse. Misusing oxycodone or fentanyl can result in the same harmful consequences as abusing heroin. Nursing and interprofessional management. Depressant use. Toxicity. Overdoses can occur when a person purposefully misuses a depressant or takes one prescribed for someone else. Unintentional overdose often occurs, especially when depressants are used with alcohol or other drugs. Depressant toxicity can cause death from respiratory and CNS depression. The priority of care is always the patient's ABCs, supporting respiratory and cardiovascular function, and continuous monitoring of neurologic status is critical until the patient is stable. The emergency management depends on the substance used and the clinical manifestations. Table 10.11. Sedative Hypnotics. On occasion, a patient with a benzodiazepine overdose may receive flumazenil, a specific benzodiazepine antagonist. Because flumazenil may have a shorter duration of action than some benzodiazepines, repeated doses may be needed until the benzodiazepine is metabolized. Place the patient on safety precautions, as flumazenil can cause seizures. There are no antagonists for barbiturates or other sedative hypnotic drugs. The patient receives supportive care, including passive rewarming, hydration, and vasopressors, along with treatments to promote drug elimination. If the airway can be maintained, activated charcoal is an option. Dialysis can be used in certain situations. Opioids. Overdose in the inpatient setting may occur when a patient inadvertently receives an incorrect dose, or when opioids are aggressively dosed, given to patients with new kidney or liver impairment, or given with drugs that potentiate respiratory depression. Treatment includes supporting respiratory function and giving the opioid antagonist naloxone. Naloxone reverses respiratory depression and other manifestations of toxicity. Monitor the patient closely because naloxone has a shorter duration of action than most opioids. Repeated doses or IV infusion of naloxone may be needed until the opioid is metabolized. Overdose in the community setting can occur when a person deliberately misuses an illegal or prescription opioid, takes an opioid in combination with other depressants, or takes an opioid prescribed for someone else. In many areas, naloxone is publicly available. This allows police, first responders, family members, and friends to give someone naloxone in emergencies, thus reversing the effects of an overdose sooner. As a result, you may see more patients requiring post-reversal care. Withdrawal. Sedative hypnotics. Withdrawal from sedative hypnotics can be life-threatening. Manifestations and treatments are similar to those of AWS. Early, the patient may have tremors, anxiety, insomnia, fever, orthostatic hypotension, and disorientation. Since the patient may experience delirium, seizures, and respiratory and cardiac arrest within 24 hours after the last dose, closely monitor the patient. Treatment consists of giving a long-acting benzodiazepine in a tapered dose. IV diazepam is an option for severe manifestations. Supportive care includes implementing patient safety and comfort measures, frequently assessing neurologic status and vital signs, and providing reassurance and orientation. Opioids. Opioid withdrawal symptoms depend on the opioid used, route of administration, and duration of use. It is usually not life-threatening, but can be extremely uncomfortable. Manifestations include intense drug craving, diaphoresis, gastrointestinal distress, restlessness, fever, insomnia, watery eyes, tremors, muscle aches, runny nose, and anxiety. With shorter-acting drugs, withdrawal may begin 4 to 6 hours after the last dose, peak in 36 to 72 hours, and last 7 to 10 days. With longer-acting drugs, manifestations may begin 24 to 48 hours after last dose and peak in 3 to 4 days. Treatment focuses on relieving symptoms and often requires drug therapy. Substituting a long-acting opioid, e.g. methadone, buprenorphine, at low doses or alpha-2 adrenergic agonists, e.g. clonidine, decreases withdrawal symptoms. Other therapies include medications for GI distress, e.g. loperamide or ondansetron, acetaminophen or nonsteroidal anti-inflammatory agents for muscle aches and fever, and antihistamines for acute anxiety and sleep disturbances. Inhalants. Persons with inhalant use disorder inhale hydrocarbon-based fumes, such as those found in glues or paints, to change their mental state. Inhalants are rapidly absorbed and reach the CNS quickly. Most are depressants with effects like those of alcohol. They cause a brief period of euphoria, followed by drowsiness and lightheadedness. Long-term use can result in neurologic problems, including damage to parts of the brain that control cognition, movement, vision, and hearing. Table 10.2. The patient with inhalant toxicity may have lethargy, dizziness, slurred speech, blurry vision, tremors, and impaired coordination. The effects usually resolve within minutes to a few hours. Inhalant toxicity is managed with supportive care. However, in some cases, users need emergency treatment for dysrhythmias, heart failure, or CNS hyperactivity, e.g. seizures. Using some inhalants, e.g. toluene, can result in nephrotoxicity, so you must monitor renal function. Withdrawal is rare, as most inhaled substances have a very short duration. Any manifestations that may occur require supportive care. Cannabis. The use of cannabis, also called marijuana or weed, continues to increase in the United States. Cannabis is available in forms that can be smoked, vaporized, or ingested. The main ingredient is tetrahydrocannabinol, THC. At low to moderate doses, THC produces euphoria, reduced anxiety, and improved appetite. Adverse effects include impaired memory, impaired motor coordination, altered judgment, and in high doses, paranoia and psychosis. Long-term use is associated with a wide range of effects, particularly on cardiopulmonary and mental health. Table 10.2. Legalizing cannabis for recreational and medical use is controversial. Sales for recreational use continue to grow. More than half of the states have legalized its use for specific medical reasons. If an HCP in one of those states determines a patient has a disorder that qualifies for medical cannabis use, the HCP can give the patient an authorization for use. This form allows the patient to buy cannabis at special dispensaries or have a limited number of cannabis plants. THC-based medications, like Marinol and Nabilone or Sesamet, are available to control nausea and vomiting from cancer chemotherapy. Dronabinol, which is Marinol, is also used to stimulate appetite in patients with acquired immunodeficiency syndrome or AIDS. Illegal synthetic cannabinoid drugs, e.g. K2 or Spice, have some of the same properties as THC. They contain varying amounts of different ingredients. The result is that these products have unpredictable effects and are more toxic. Sometimes death has occurred with one use. Patients with acute marijuana toxicity can present with acute psychotic episodes, especially if the patient used a synthetic derivative. Cannabis can induce tachycardia and hypertension, triggering dysrhythmias and myocardial infarction. Support the patient's ABCs. Panic and flashbacks are managed by maintaining a quiet environment and reassuring the patient. Benzodiazepines give symptom relief. Withdrawal can occur in a hospitalized patient who uses cannabis. The patient may have irritability, insomnia, anorexia, cramping, mild agitation, and nausea. This peaks about 48 hours after cessation and may be more severe in women. There is no specific drug therapy for treating withdrawal. Supportive care includes measures to promote sleep, safety, and patient comfort, including analgesics and hydration. Caffeine. Caffeine is the most widely used psychoactive substance in the world. It is very weak when compared with other stimulants. Most people use it to promote wakefulness. Other uses include promoting motor activity and treating headaches. Its use is safe in most people. Problems from high doses of caffeine have occurred in association with specialized drinks. A large caffeine intake can cause cardiac dysrhythmias, hypertension, disturbed sleep, seizures, and anxiety. Treatment consists of seizure control with benzodiazepines and supportive care until the effects wear off. In a hospitalized patient, caffeine withdrawal can result in muscle pain or stiffness, drowsiness, irritability, and headaches after general anesthesia or during restrictions on usual caffeine intake. Nursing management, substance use. Nursing assessment. You need to be able to determine if patients use substances in a way that places them at risk or if SUD is present. Screening is a simple, effective way to identify patients who need further assessment. Use the screening, brief intervention, and referral to treatment, or SBIRT approach. SBIRT consists of 3 parts. 1. Screening to quickly identify and assess the severity of any substance use problems. 2. Providing a brief intervention or teaching patients about the consequences of substance use. And 3. Referring those who screen positive for further treatment. Screening is the first part of SBIRT. Use screening tools to identify those who may have problems with substance use. As a baseline, ask every patient about the use of all substances, including prescribed medications, OTC medications, caffeine, tobacco, and recreational drugs. Use simple 1 or 2 question screening tests to detect alcohol, tobacco, and/or other substance use problems. Table 10.12. If a patient has a positive screen, follow up with a detailed assessment to identify specific problems. A screening tool for AUD, the Alcohol-Use Disorders Identification Test, is shown in Table 10.13. A score of 8 points or more in men or 7 or more in women is concerning. Another useful tool is the Drug Abuse Screen Test, DUST-10, shown in Table 10.14. If there's a sign of substance abuse, figure out when the patient last used a substance. Knowing this information will let you know when to expect the onset of withdrawal and help you anticipate drug interactions. Assess for factors that influence the onset of withdrawal, including the substance used, dose taken, method of intake, and length of time the patient has used a substance. You may discover that the patient is dealing with polysubstance use or the use of more than one substance. Alert the HCP as these patients need care tailored to the combination of substances used. You may find problems associated with substance use during your physical assessment. Assess the patient's general appearance and nutritional status. Examine the abdomen, skin, cardiovascular, respiratory, and neurologic systems. The presence of a mental health disorder such as anxiety, bipolar disorder, or depression increases the risk for SUD. Serum and urine drug screens can identify the type and amounts of drugs present in the body. A complete blood count, serum electrolytes, blood urea nitrogen, creatinine, and liver function tests evaluate for electrolyte imbalances and cardiac, kidney, or liver dysfunction. During your assessment, look for patient behaviors such as denial, avoidance, under-reporting or minimizing substance use, or giving inaccurate information. Behaviors and physical manifestations suggesting substance use are outlined in Table 10.15. However, these behaviors are not all-inclusive. Nursing diagnoses. Nursing diagnoses for the patient with substance use disorder include substance abuse, drug, alcohol, and/or tobacco, risk for injury, acute confusion, altered perception. Planning. Nursing care focuses on the priority problems of reducing the risk for injury and managing acute confusion. The overall goals are that the patient with a substance use problem will 1. Have normal physiological functioning, 2. Acknowledge a substance use problem, 3. Explain the physiologic and psychologic effects of substance abuse, 4. Abstain from substance use, and 5. Cooperate with a proposed treatment plan. Nursing implementation. Health promotion. Your role in health promotion includes prevention and early detection of substance abuse. Prevention measures include abstaining from harmful substances, and limiting alcohol use. These measures decrease the risk for substance-related injury or illness. You can help prevent substance use problems by 1. Teaching about the effects and negative outcomes of substance use, and 2. Providing support. Through screening, you have an opportunity to prevent patients from becoming dependent on alcohol and drugs. You can do this by using brief interventional techniques and helping patients access appropriate care through referral to treatment if they show risky behaviors or are already dependent. Acute intervention. The immediate result of overconsumption is acute toxicity or overdose. The patient may also present with trauma or injuries. The priority of care is supporting the patient's ABCs, especially respiratory status. In addition to treating injuries, provide supportive care until detoxification can occur. Nursing care includes frequently assessing neurologic status and vital signs, giving IV fluids to prevent dehydration, oriented to time and place, and implementing patient safety measures. Sometimes, uncertainty exists as to what substances are involved. If the patient used multiple substances, a complex clinical picture can result. For example, a patient presents with toxicity, and the healthcare team does not know what substances are involved. Although blood and urine tests will help identify the substances, treatment is started while waiting for the test results. The patient in this situation would usually receive naloxone. If the substance used is a barbiturate or another CNS depressant, naloxone will not help the patient, but it will not hurt the patient either. If the patient does not respond to a total dose of 10 milligrams of naloxone, it is unlikely opioids are involved. Once acute health issues are resolved, provide a brief intervention to teach patients about the consequences of substance use and support behavioral change. When patients have a substance use problem, it is critical to motivate the patient to engage in long-term treatment. You are in a unique position to facilitate behavior change. When a patient seeks care for health problems related to substance use, or when hospitalization interferes with the usual pattern of use, the patient's awareness of any substance use problem increases. Intervention at this time can promote behavior change. Take an active role in performing motivational interviewing and providing counseling aimed at cessation. Motivational interviewing is discussed in Chapter 4. Discuss the risks associated with substance use and provide feedback and advice. If the patient agrees, assist with referral to counseling or behavioral therapy. Gerontologic considerations. Substance abuse. Substance use in older adults is a fast-growing and often hard-to-recognize problem. Older adults do not fit the image of users. For example, older users are less likely to binge drink and use different substances than younger users. The effects of alcohol and drugs can be mistaken for medical conditions common among older adults, e.g. hypertension and dementia. So we may attribute substance use problems to another cause and not offer treatment. Some use alcohol or drugs to cope with grief and loss issues, such as the death of a spouse. Because of the higher rate of coexisting medical problems, older adults are at greater risk for medical problems associated with substance use. Common problems include liver damage and cardiovascular, GI, and endocrine problems. Substance use may cause confusion, delirium, memory loss, and neuromuscular impairment. Physiologic changes may lead to toxicity at levels that may not have been a problem at a younger age. Withdrawal symptoms may be more severe than in younger persons. It is important to screen older adults for substance use. Family members are important sources of information, Figure 10.4. Other potential sources include friends, home health aides, meal delivery personnel, and staff members at senior citizen centers and long-term care facilities. It is important for you to discuss drug and alcohol use with older adult patients, including OTC and herbal drug use. Assess the patient's knowledge of currently used drugs. Common screening questionnaires may not identify an older adult with a substance use problem. The short Michigan Alcoholism Screening Test, geriatric version, SMAS-G, is a short-form alcoholism screening instrument for older adults that can identify older adults with potential AUD. Smoking and other tobacco use is another issue. Those who have smoked for decades may feel unable to stop or believe there is no benefit to stopping at an advanced age. However, smoking contributes to and worsens many chronic illnesses found in the older adult population. Smoking cessation at any age is beneficial. The information about smoking cessation discussed earlier is appropriate for helping older adults with smoking cessation, tables 10.3 to 10.6. Patient teaching for the older adult includes teaching about the desired effect, possible side effects, and proper use of prescribed and OTC drugs. When you suspect alcohol or substance use, refer the patient for treatment. It is a mistaken belief that older people have little to gain from alcohol and drug dependence treatment. The rewards of treatment can lead to greater quality and quantity of life for older adults. And that is it for Chapter 10.